Hi everyone. Next session is the Doppler of the AV fistula. So we'll see, we'll take 3-4 things in our mind. One, we'll see the radial artery or the in broad, we'll see the feeding artery, radial or the brachial. Then we'll see the fistula, anastomosis. Third thing will be the Juxta anastomotic segment, means first 3-4 centimeters, and then the body of AVF and the outflow of the fistula. So we'll start with the probe. I have taken the linear probe. This is the linear probe. Its frequency is 6 to 13 megahertz. So we used it this to look for the superficial structures. Now we'll see the position of the patient is a spine with the arm resting on the bed. So this is the fistula. This is the radiocephalic fistula in the wrist. So there will be the feeding artery. There is a anastomosis and the juxta anastomotic segment. Then the body of AVF and the outflow. We have to see first the proximal part of the radial artery, then anastomosis, then juxta anastomotic segment and the body of AV fistula, and then the outflow. We'll see the main outflow. Is it the basalic vein or is it the cephalic vein? We'll see. Now we have this probe and the patient is a normal functioning fistula, and now we'll see first we'll screen the proximal radial artery or the feeding artery. This is the feeding artery. I will try to screen the feeding artery. So this is the radial artery with the vena comitans, the good caliber artery. I'm doing the scan at the 4 centimeter above from the fistula. That means this is a proximal 4 centimeter from the anastomosis. I'll freeze the image, then take a caliber. So I'm measuring the diameter of the radial artery. So it's a very good caliber radial artery, well developed, well matured. After fistula, the artery also matures and the vein also matures. So the size of the artery is usually 0.2, 0.3, so it has increased to 4.6 mm. And now I will see the flow. There is a good flow in the systole and the diastole. There's a whole, the flow is, the blood is flowing in the systole, in the diastole. There's a triphasic flow. Nice calibered radial artery. I am going down, down, down till I screen it till the anastomosis. See now, see this is the anastomosis. Now you can see this is the radial artery. It's joined by the cephalic vein. I will just make some adjustment to see it more clearly. I want to see the arteriotomy. This is the radial artery and this is the anastomosis. This is the vein, this is the artery, and this is the anastomotic side. So in transverse view, this is the portion of anastomosis. So this is the anastomotic site. I'll freeze it, take a caliper and measure the arteriotomy site. This is the arteriotomy. So there is a rent of 2.5 mm in the artery. Now I will check the flow. Color Doppler. So there is a lot of aliasing. Make adjustment and then take a Doppler. So this is a high flow fistula. The PSV is around 400. So this is a significant PSV. So there's a broad complex. This is the systole. This is the broad diastole, followed by again the systole. We'll again see the Juxta anastomotic segment. We'll now try to see the Juxta. This is the artery. This is the anastomosis. My probe is transverse to this longitudinal to the fistula, the line of the fistula. So there's a minimal pressure that I want to take a diameter of the Juxta anastomotic segment. So this is the Juxta anastomotic segment. This is the anastomosis here, and from there there's a Juxta anastomotic segment. I am taking the diameter of the Juxta anastomotic segment first. So it's around 2.3 mm. Here it's around 2.2 mm. And then here its diameter increases and it's around double of that. It's around 4.2 mm. So this is the around 2 centimeter from the anastomosis. Now as we have checked this segment, that means from the anastomosis, then Juxta anastomotic segment, it's around 2.3 mm, first around 1.5 centimeter, then the diameter increased to 4.2 mm. So this is the Juxta anastomotic segment. I'm screening it. So this is the vein. Here the vein is around it was 4.2 mm. It's around 4 mm vein, and from there I will screen in the transverse section. First I will screen the transverse section. So what is happening here, this is the vein. Look at this vein. See now, this vein is breaking into two. There are two veins now. One is going lateral to the arm, one is running in middle of the arm, and again that branch is again joining back to this vein and forming a single vein. I am screening it to upper till the elbow. So at elbow, this vein is joining. This vein is joining again median cubital vein and then breaking again into two. One is going this is again, there is one more vein, this branch, this is the main vein, this again joining median cubital vein, then breaking into two, the cephalic vein of arm and the basalic vein of arm. So we'll take diameters. So we'll write down that there at the 2.5 centimeters, the vein is breaking into two. The vein is breaking into two. There's a branch, and one more branch is joining the other branch. This one, and forming the lateral vein. And we'll see the flow now in the main vein. There are also now three veins. We have to see flow in all the veins and to confirm that is it there the accessory veins or not. First, let's check the vein. First we'll check this vein. Check this vein. No, there is a least flow in it, very less flow with the peak systolic velocity of around 10-15, not much. Now we'll see this vein, this vein. One is this vein, one is the vein in the middle. Now I'll check this vein. The flow in this vein, we'll see. There's a good flow around peak systolic velocity of 120. Now we'll check a flow in this vein. Yes, this vein is also getting flow of around 120 peak systolic velocity. Then this vein actually it joins this is the main body of fistula now. We have reached around 5 centimeters from the anastomosis. So I'll check the flow and the peak systolic velocity of this segment. The flow volume, we'll check the diameter. So the flow is 130 ml per minute, but we'll check it again, we'll confirm again. This is the vein at around 5 centimeters from the anastomosis. Check the Doppler. So the flow is here is around 173 ml per minute. It's not that good flow, but as we saw, the cause for this problem is that, again I will show you, at the site of the fistula, see the peak systolic velocity. We'll again check the same thing. First the diameter, try to get a diameter. One, and then we check the timed average velocity. So the flow is here, it is 504 ml per minute. It looks okay and very good fistula near to 500. But then what happens? This was 1 centimeter from the fistula. This is the anastomosis and this is the segment. Then what is happening actually? See, what is happening? So this vein is dividing into 1 and 2 veins. So half of this is taken by one vein, half is taken by other vein. Even there are 3 veins. See, this is one vein, this is another vein, and this one is third vein with the minimal flow. So this one is having minimal flow. This one is having, say, peak systolic velocity of 120, 130. This one is having peak systolic velocity of 150. And the flow in this is around 180 ml, 150 ml, and this is actually around 150, 160 ml. And there's a minimal flow in this. So this is probably the accessory vein, which is not tied. Actually, this branch has been not tried during the surgery. So we'll follow the lateral vein, see where it is going. It's going on the lateral and it's just ending here and joining the cephalic vein of the arm. And the main vein this is the body of AVR. This is the main vein at near elbow. Near elbow it's joined, see, this is joined from it's a deep vein. This is a deep vein, this is a brachial artery, this is a deep vein, vena comitans. It's one vein, median cubital vein, coming and joining the cephalic vein of the forearm, and then again dividing. This is again dividing, and this is the going to form a cephalic vein of arm, and we'll see now how much flow is in the cephalic vein. So we have to find out the outflow vein. So we'll see now the outflow vein. Not much flow in it. Not much flow in it. So we'll see now the basalic vein. It is dividing into two. So this is the basalic vein. Join, and now this is the basalic vein. It's again dividing into two. This is the basalic vein. So we'll see the flow in this vein as outflow. Yes, it appears that it is there. One moment. One more time. We'll do this. So this is a more flow. Yes, this appears that there is outflow is through the basalic vein of the arm. So we'll do one thing. We'll just follow this vein. Increase the depth, because now this will go deep. I have reached the upper part of the arm. See what is happening. This is the basalic vein. It's around 3 centimeters from the elbow. Now this vein is joined by some other vein here, the branch of there, and now see, look at this. This is the brachial artery, this is the basalic vein. Now this vein is running along the brachial artery as a vena comitans. Now this vein is again joined by the vena comitans of the brachial artery, and I reached almost to the axilla, and it's continuing as the axillary vein. See now the flow here.
Excuse me. Sorry, sir. I'm so sorry.
There's a respiratory variations also. So the outflow vein is the basalic vein. So we have seen the central veins. We'll look for the central veins also, because there's a history of catheterization in this patient also. So we'll see, this is the internal jugular vein. It's patent. There's a There is no thrombus. It's widely patent, and I can see also central vein, the brachiocephalic vein, which is joined by the brachiocephalic vein of the opposite side also. So it's widely patent. You can take the peak systolic velocity. There's a respiratory variations, so that means the superior vena cava is patent and it's continuous with right atrium. There is no obstruction. I will see also on the left side. So left side, this is the internal jugular vein, this is the carotid artery. I'll go down and I'll see this is the basalic vein turning to the left, right. This is the turn, and this is joined by this. This is the heart, right atrium. And we'll see the patency. Yes, there is a respiratory variations also. So we have seen the fistula, we have screened the radial artery, proximal 4 centimeters, then we have seen the anastomosis, then the Juxta anastomotic segment at 1.52 centimeter, there is a branching accessory vein, the blood is taken by the one vein, half of the blood is taken by another vein, and the third vein is there, the branch. It's a very small branch, not taking much of the blood, but now if there is a problem with flow, if there is a suction during dialysis, flow issues, it's not sustaining more than 300 blood flow, QB of 300 or more, so that in that case we can ask for the ligation of the this accessory vein. Yes, we can do that. We can, because it's very superficial, we can do the percutaneous ultrasound guided ligation also. So and he will be benefited if there is a flow issues. Outflow, we have seen the body of AVF and the outflow vein. Outflow vein is the mainly by the basilic vein of the arm, and which is continuing as the axillary vein with the patent internal jugular, brachiocephalic, and the superior vena cava. We have seen that, and that ends my session. Okay.